Today we're going to talk a bit about negative symptoms and depression. It's very hard to tease out what's what between those two. So let's start with negative symptoms. Negative symptoms, I'm sure as you're aware, are transdiagnostic. And with schizophrenia spectrum disorders, they seem to be pretty good predictors of the outcome in schizophrenia. It used to be thought, I believe, that negative symptoms, if they stayed stable during that first year or that prodromal year, the outcome was pretty negative. But there has been some recent research that suggests that negative symptoms can go up and down throughout the first 5 years. So just because we've got clients that do have negative symptoms that are pretty severe during that first year doesn't mean that they cannot be addressed and targeted. So individuals with schizophrenia who have negative symptoms, basically their, what's the word that I'm looking for? Their ability to anticipate and enjoy a pleasurable event is much reduced. And as a result of that, their goal-oriented behavior declines as well. So when depression is mild, you can actually see a difference between the depression and the negative symptomology. However, when the depression is pretty severe, it's of course really tough to tell the difference. So first of all, we're going to talk about negative symptoms. We'll then go into depression because it's hard to tease out the two. And finally, we'll take a look at some potential interventions. So here I've got a chart that takes a look at the similarities and differences between negative symptoms and depression. As you look at the list, you can see that certainly there are some commonalities between the two lists, but you can also see that with negative symptoms, there's more of a sense of emptiness, flatness, just not feeling anything at all. With depression, there's more emotionality. There's some guilt. There's often a lot of shame. There's sleep issues, eating issues, along with the inability to concentrate. So when we're looking at somebody with negative symptoms, we see someone who just kind of looks empty without any emotionality. And in the words of Pat Deegan, she put it so beautifully when she described her own negative symptoms. She said giving up wasn't a problem. It was a solution, basically. Because it protected her from wanting anything. If she didn't want anything, it couldn't be taken away. If she didn't try, she wouldn't have to undergo another failure, didn't care, nothing could hurt her again, and her heart had become hardened. As I look at that quote, it kind of looks like negative symptoms are a choice, but I don't think that that's necessarily true at all. I think that negative symptoms and depression get so intermingled that perhaps when one is just best friends with the other. So there are some explanations for negative symptoms. Some research will say that is simply at times a component of the disorder of schizophrenia. But some other common explanations are that medication can certainly cause that flat affect. It can look like somebody is lazy, but that's not the case. Medications can sedate somebody and it just looks like they don't care. But what we really know is that people become overwhelmed by their experiences when they're struggling with schizophrenia. In fact, they're probably struggling with emotion regulation. And of course, they have developed some beliefs which interfere with acting on goals. There's been some research that I had read over the last year which indicated that sometimes people's systems are so overstimulated by outside stimulus that their physical response is to just simply shut down, and that's what looks like that negative symptom. Defeatist beliefs are a big part of negative symptoms as well. Because there's a low expectancy for pleasure, nobody's going to expect that they're going to succeed very much. A lot of stigma is a part of that. And people believe that they just don't have the resources to get any better. And so the belief is it's better not to try than to try and fail. And it has been shown that some beliefs are a mediating variable between cognitive impairment and negative symptomology and poor functioning. So if we can target those defeatist beliefs, then there is a possibility that we can reverse some of that negative symptomology. Because when the beliefs get turned around, we see an increase in engagement and an increase in pleasurable activities, and in fact, an increase in some neurocognitive functioning. So let's move on to depression. Depression is a part of schizophrenia at times. Sometimes there can be a major depressive episode within the struggle of schizophrenia. Sometimes it can be subclinical. But it is the most common factor in completing suicide, actually, more so than command hallucinations. And when we look at negative symptoms, by the way, along with depression, we see that those symptoms actually are different. They are what they would call orthogonal. They are separate from one another. We can pull them apart, even though it can be very hard to do. Depression has also been linked with worse functional recovery, worse quality of life, and particularly in the first year when with adolescence, if an adolescent is experiencing depression, that depression can be predictive of transition to psychosis. So oftentimes there's basically three ways that people end up in a depressed episode with schizophrenia, and that is that it can be a core dimension of psychosis, like negative symptoms. Depression is also a shame-based response to just simply being diagnosed with schizophrenia and all the consequences that brings. It's also a telltale sign of historical childhood abuse. And so a thorough assessment is really important to tease out some of those factors. Oftentimes there's a post-psychotic depression after that first episode of psychosis. And so as a result of that, ways to target that depression and work with it are to work on the grief and loss associated with their diagnosis. We need to work at finding some real meaning in life for them, what they value, what they find helpful, and to find some motivation to move forward. It has been shown as well that an individual who has better insight into their diagnosis may experience a greater sense of loss, feelings of humiliation, and just a lower self-esteem. And that can also contribute to suicidal ideation and gestures. By the way, that better insight used to belong, and the suicidal ideation used to belong to white upper middle class or middle class males. Now it is evident as well in females who have had a career or are on a career trajectory who have had a first episode. Shame is huge in the role of depression. Shame is often, it just incapacitates people. Their sense of incompetence and disgust is huge. There's two kinds of shame that we work with. One is internal, which is shame that one has about oneself. I would call that trait shame. So some folks just kind of have a propensity to take responsibility for everything, including the sun rising and the sun setting, even when it's not, their responsibility. External shame comes when we believe that somebody else doesn't like us because of something in me. So that external shame is what we're really dealing with. Those with externalized shame are responding to stigma. And there has been some treatment modalities that have been specifically targeted for that reduction in external shame. So CBT has some good research about that. Compassion-focused therapy is also very good at heightening a sense of compassion for oneself and is very good about reducing that shame. It's one of its core tenets is non-judgmentalness of others as well as oneself. Just a great research on compassion-focused therapy. So in terms of intervention, what we want to do with negative symptoms and depression is first kind of center ourselves with and increase our own empathy. Can we imagine having the loss of control, job, income, all the exciting things that are supposed to happen in life, all of a sudden taking a turnaround? That's incredibly hard, actually, with any huge chronic disease, especially so with schizophrenia, and if there's some insight to that. They've lost their identity. Hope can go right down the drain, and relationships, of course, become very difficult. Think about what it would be like, for example, to recover from a physical injury, losing a leg or losing an arm, and what impact that might have on your life. And it's the same with negative symptoms, depression, and schizophrenia. It's small steps. You have to go a little bit at a time and adjust your expectations. Exercise is an excellent antidote for depression and negative symptoms. So getting active, thinking about something that you want to do but haven't gotten around to doing it. Think about when you want to begin an exercise program, or when you want to begin to diet, or when you want to begin some kind of hobby that you've been meaning to do and you haven't gotten around to it. What are the ways that you motivate yourself? I know for me, I might set up a space, I might set up a schedule, and sometimes I'll make myself do it, whatever it is, even if I don't want to do it. And we use some of those interventions with our clients as well. But we want to focus on kind of long-term goals with activities and hopes, so that we reduce the pressure of trying to hit a goal immediately. So we want to take a look at what are the overall values that are of interest to this client. It may be that they want to go back to school, that they want to become an artist, they want to become an actor. That's great. And so what we do is set out some small steps to begin with and work ever so slowly towards the bigger goal. Some of the ways to get at those interests are to use the card sort that's available and worksheets, which are all about values and activities. Behavior activation is very good. As I said, exercise is very good. We want to increase the client's ability to have a sense of success. We want to look at linking behavior with mood, and mastering something is going to heighten that mood. So helping to plan real simple activities into the day and schedule the day can be very good. It adds structure, and even attempting is cause for success. So schedule something and have them do some rating about what they think their pleasure is going to be around that, and then what the actual pleasure is. And I know that sounds like a tall order when we're sitting with a client who's having a hard time paying attention. And so again, we do it in very small steps. It's just simply about reestablishing some structure in the day. Here is an activity monitor. That's pretty simple, and you could probably recreate that, and I'm sure you all probably have one sitting in a desk somewhere. This is hard to do for anybody, let alone somebody who's struggling with concentration issues. So what I will do sometimes is give this to my clients and say, you know, one day, let me know something that you did so I get an idea about what they're doing at least one point during the day. And then we keep working on it as days go by. After a while, we can take that list and use it to plan activities. We can plan an activity and they may do it, they may do another activity, and so they write this down and then rate how pleasant that experience was for them and how productive they felt when they were engaged in that activity. Again, that takes kind of a while to work up to, but it's doable. Sometimes we'll take a sensory walk around the center that I work in. If somebody feels too overwhelmed, we'll just get up, walk around inside the building, look at some of the paintings on the wall, talk about them, have them feel different textures. I have a thing of rocks in my office and we can feel the smoothness of the rocks and take a look at the striations in them. Anything that heightens their sensory abilities, sight, sound, smell, touch, and physical activity. Practicing simple coping strategies like relaxation, breathing, grounding, imagery, body scan, gratitude lists are all ways to boost, to help boost somebody's mood just in the moment. And then, of course, if you can, have them write before and after the activity so that they can see that in the space of 5 or 10 minutes, they've really changed their emotional mood. This is a procedure, a broad-minded affective coping procedure. That's a big mouthful for quite a simple thing. It is behind positive psychology. It came from positive psychology. And basically what this is having the client say to you what a fond memory was for them. And they tell it to you, have them give as much information as they can about the memory. And the idea then is to have them relax, have them take some deep breaths and sit in the chair while you recount that memory back to them with as much sensory information as you possibly can. The idea behind this is that if somebody has a better mood or an uplifted emotion, they're much better able to retain what they're learning in the session. So sometimes beginning a session with this will just simply help the session go better for them. Loving kindness meditation is also very good, although this is kind of difficult to do if you're not familiar with it. And it's a difficult exercise, even for me at some time, and I do this pretty regularly. It is simply about learning to wish oneself and somebody else happiness and peace and love, and an understanding of where all that comes from. It is rooted in ancient Buddhist meditation and a practice of metta. And most people kind of do have a difficult time with this because the very last thing that we do is to extend a wish for health and safety to ourselves. However, if we practice a little bit at a time, and you can find this loving kindness meditation description pretty much anywhere online, it really does change the sense of emotionality. It increases compassion and empathy and increases compassion for oneself as well. I would encourage anybody who wants to do that to try that with themselves as first before you try it on somebody else, and perhaps to get some guidance by somebody who's been practicing meditation. Psychosocial interventions are very good. Here are 2 books that we use here in our CBT program. Cognitive Behavioral Social Skills Training for Schizophrenia by Eric Granholm and Company, and Treating Psychosis, A Clinician's Guide to Integrating Acceptance and Commitment Therapy by Nicola Wright and Company. Both are excellent. One is more strictly behavioral social skills, and the other is really built around mindfulness and commitment therapy, which has been shown to have some terrific results with depression and negative symptoms. I think it's important to encourage clients to write a summary of what's happened in the session when you're working with these symptoms. Have them put it into their own words, have them make a list. And this may even begin to help them see their own negative thinking and begin to change that around a little bit. So the question, can people with schizophrenia be happy? And survey says yes. Happiness within schizophrenia is absolutely possible. Our own Dr. Messamore, with his newsletter, found some great research that variables including perceived stress, resilience, optimism, and personal mastery were all associated with happiness. So if we can target these and build these and change these around, then people with schizophrenia or psychosis or any other chronic disease can begin to feel some happiness again. So I love this. Optimism can be learned, resilience skills can be taught, stressors can often be managed, and one's responses to stress can be modified. Learning and practicing these skills is worthwhile for anyone, so it stands to reason that they may be especially worthwhile for people with illness. So there we go. And I think that that's about it. So here's a quick summary. Be mindful, lower pressure, small steps, simple activities. And we're open for questions if there are any.
Thank you, Val.